Good afternoon, class. Good afternoon, everyone. Good afternoon, Dr. Willis. Um, my second drug of choice was Lexapro, so I'm going to go over it in briefly and also present you two case studies where it will be appropriate to prescribe Lexapro and when it's not appropriate to prescribe Lexapro. So Lexapro is also called escitalopram. It is a selective serotonin reuptake inhibitor, commonly prescribed for the treatment of major depressive disorder, generalized anxiety disorder, and panic disorder. It works by increasing the level of serotonin in the brain, which helps improve mood and reduce anxiety. The dosage available in the tablet form are 5 mg, 10 mg, and 20 mg. Side effects of Lexapro. The common side effects are nausea, dry mouth, headaches, insomnia, dizziness, sexual dysfunction. Adverse effects that are rare but are serious adverse effects are allergic reaction, seizures, serotonin syndrome, and increased risk for suicidal thought and thinking and behavior, especially in the young adult. The first case study here is talking about a patient who is appropriate to take Lexapro. MJ is a 30-year-old female Caucasian. She's a social worker. She's married and she has a son. She drinks occasional glass of wine. She doesn't take any recreational drug at this time, but when she was in college, she did some weed. So her chief complaint today is persistent sadness, loss of interest in in pleasurable activities, fatigue, difficulty concentrating, and feels overwhelmed by her responsibilities at work and at home. The symptoms have been present for several months now. Past medical history of obesity, past mental history of postpartum depression, no known psychiatric mental disorder, no known family history of psychiatric mental disorder, my bad. She just takes a multivitamin and occasionally she takes some melatonin when she has difficulty sleeping. When she had PPD, she was given sertraline 100 mg to take daily. And then she said it did not really work. It's after she went back to work that she started feeling better. So upon assessment, MJ meets the criteria of major depressive disorder based on the DSM-5 criteria. She has history of depressive episode PPD and did not respond well to the sertraline according to her. Isolated code 33 F33.1. Differential diagnosis: I had bipolar disorder. I was ruled out because bipolar disorder has the symptoms of heightening mood, and MJ did not disclose any heightening mood. The other differential diagnosis I had was adjustment disorder with depressed mood. It usually occurs, usually has the depressive symptoms, but it usually occurs with a stressor. MJ did not disclose any stressor, so this was eliminated. Her treatment, given MJ's symptoms and history, initial treatment would be Lexapro 10 mg daily, with the option to titrate it up to 20 mg based on her response and tolerability. We'll discuss the potential benefits and side effects of Lexapro with MJ, and we'll make sure we always obtain informed consent to start on the treatment. So Lexapro is chosen as the first line pharmacological treatment for MJ due to its efficacy in treating depression and its favorable side effects. And as an SSRI, Lexapro has demonstrated efficacy in improving mood symptoms and is generally well tolerated by patients. Usually start on a low dose and we gradually titrate it until we achieve therapeutic effects while we are minimizing side effects. MJ is expected to experience improvement in her depressive symptoms within 4 to 6 weeks of starting medication. Regular follow-up are important so that we can monitor her response to treatment, adjust the medication if necessary, and provide ongoing support and psychoeducation. So for follow-up, we want to monitor therapeutic response, including the improvement in mood and reduction of anxiety symptoms. We want to monitor for side effects and adverse reaction, especially the first weeks of starting the treatment. We want to assess for worsening depression symptoms. We want to regular monitor vital signs, including blood pressure and heart rate. We want to monitor also her sodium level, because Lexapro has also been known to have side effects of hyponatremia, and also it has side effect to cause liver disease. So we're also going to monitor her liver disease, and then we'll monitor for potential drug interaction if she's taking any herbal, although she mentioned only that she's taking multivitamin. So cultural consideration is important to recognize cultural factors that may influence MJ perception of mental health and treatment preference. Okay, so we're going to adopt a culturally sensitive approach, actively involving MJ in decision-making process and addressing any cultural concern or barriers to treatment adherence. The second case study who is not appropriate for Lexapro is JD. JD is a 50-year-old male Hispanic. He's lost his job last year due to showing up at work intoxicated with alcohol. He's separated from his wife. He has 2 sons. They're 18 and 16. He acknowledged that he has been burned drinking recently and says that his personal issues and alcoholism are overwhelming and depressing him. So his chief complaint today are SI, persistent sadness, loss of interest in pleasure activities. The symptoms has been present in the past several months. They are on and off. Past medical history of hypertension, pancreatitis, abnormal liver enzymes. He was sent to go do an ultrasound of his abdomen. He never went. So we don't know if he does have hepatic, if he has any kind of fatty liver. We don't know. But he has past mental history of alcohol dependence, history of major depressive disorder. When he lost his job, he was diagnosed then, and then he just recently came out of the hospital for alcohol withdrawal. Family history: his father was an alcoholic. His father died at the age of 55 from a heart attack. Current medication: he stopped taking his medication, but he was prescribed naltrexone 50 mg POQD and propranolol 80 mg POQD several months ago, because he just stopped taking the medication because he just wanted to drink. And then for the psychiatric medication, he had Ativan 0.5 mg, and he also had Wellbutrin 150 that he stopped taking too, because he said he just wanted to drink in peace. Primary diagnosis is MDD, as evidenced by his symptoms that he presented. Differential diagnosis: I had adjustment disorder, because his symptoms have been, he has a stressor. The symptom has been within 3 months, but they have been more than 3 months, because he was before diagnosed with MDD. So that's why I roll out adjustment disorder. And of course, substance use disorder, substance induced depressive disorder, because he's drinking alcohol. It might also be substance induced depressive disorder. So his treatment: given the history of liver disease and substance use disorder, avoiding prescription of Lexapro and other SSRIs should be taken into consideration. Okay, because I had the side effect of hepatotoxicity and potential interaction with alcohol. For him, we'll have to do supportive care, monitor for alcohol withdrawal symptoms, arranging appropriate follow-up with addiction medicine specialists. He was also encouraged to attend AA meetings and to get a sponsor. Okay, so usually patients with significant liver impairment should not take Lexapro because of the hepatotoxicity. Also, if there is using substance like alcohol, they should not be taking SSRIs because of the hepatotoxicity. So expected outcome: so while he was in the emergency room 2 weeks ago, he was given supportive care like hydration, nutrition. He was observed for signs of alcohol withdrawal while he was hospitalized. He is referred to a specialist in addiction medicine. And then in order to treat his emotional suffering and suicidal thoughts, mental resources are also offered, like psychotherapy, therapies, counseling, AA meetings, getting a sponsor. So given that he's also jobless, he also might benefit from a psychiatry rehabilitation program where he will get help finding with applying for jobs. Cultural consideration. The healthcare team recognized the importance of addressing JD's cultural background and its impact on the substance use and mental health. They strive to provide cultural competent care by engaging JD in open and non-judgmental communication, respecting his autonomy and treatment preference, and involving his family or any support network that he has. Lesson learned from these case studies. I'll learn that escitalopram or Lexapro can be an effective pharmacological treatment for depression and anxiety disorders in appropriate patients. However, it should be used carefully in patients with comorbidity such as liver disease or substance use disorder, where potential risk may outweigh benefits. Cultural factors may play a significant role in treatment decisions, and require a patient-centered approach. And these are my references, and thank you for listening.